Dear friends, my name is Mahmoud Ratib. I am Associate Professor of Ophthalmology from Egypt. I'm happy to present this case of neglected traumatic cataract in a 20-year-old female who presented to me, myself in the clinic with a hand motion vision. And you can see here that the iris and the lens, there are strong adhesions between both. There's like huge sclerosis pupillae, very disfiguring, and areas of multiple iris atrophy. In these cases, I usually do multiple paracentesis at the beginning of the case, because you never know, at the middle of the case the eye may go hypotenuse, and you cannot do those paracentesis. And I usually use Trabant blue to help me to delineate the anterior capsule, although it's very hard in this case, but I usually do it. I use copious amounts of OVD, especially Helan, to give me space and to protect the cornea, the endothelium of the cornea. I use a bent hypodermic needle, to try to free the iris from the very thick, very tough anterior capsule. And the video here is very fast, but I spend some time to liberate the iris from the thick anterior capsule. And I'm sure that at the end there will be a very large iris defect, but first I have to deal with the lens, and then I will come to the iris afterhand. Again, use copious amount of OVD to clear your path through the eye and not to damage the endothelium of the cornea. I use micro scissors and micro forceps to cut to hold and cut the thick anterior capsule, because neither phaco nor vitrectomy will help me. You can see here how tough it was to cut and get the anterior capsule out of the way. Always try to be keen on the endothelium of the cornea, because you don't want a very hazy cornea in the first week after surgery, after all what you have done in the case. You can see how tough and thick the anterior capsule and also the lens material adherent to the capsule. The second step is to clean out and take the lens material out the eye. So basically the IA of no help in this case. It's very important to remove all the lens material, because it causes very intense reactions post-operatively. So I still use the micro forceps and the micro scissor to cut all the lens anterior capsule remnants. Then here comes the anterior vitrectomy cutter. So sometimes it does iris damage in order to get a chance to remove the lens cortex, which was very tough as well. And here's one of the important tips, that when you use the anterior chamber anterior vitrectomy, you always do the aspiration in a higher level than the anterior vitrector, because when you do vitrectomy in anterior to the fluid, it will make the vitreous come from the back of the eye to the anterior of the eye. from the posterior segment to the anterior segment. But when the vitrectomy cutter is below the fluid, the vitreous will move from the anterior part of the eye to the posterior part of the eye. I still use the micro forceps and the scissor to remove all the anterior capsule. Very adherent. Now it's time for triamcinolone. The TA is the best for vitreous cleanup. No matter how much time you spend on anterior vitrectomy, after T injection, you will always find it was never enough. So it's very important. Also, I use it without any dilution because I love to have some particles of triamcinolone remain in the eye because it will help to decrease postoperative reaction and inflammation. It was very important that to know that cystoid macular edema is very common on those patients. I shifted now to the red reflex enhancer, and I put the three-piece IOL with posterior optical capture, and this is the best way because this is the best way to have a very stable IOL in this very traumatized eye. So my plan now is to try to release the dilated atrophic iris tissue to get a decent grip for pupilloplasty. Be gentle and use OVD a lot. Micro forceps, micro scissor, micro instruments, and sometimes aspiration is used to grab the iris. It's very friable, especially in these traumatic cases. I also use myocol to help me sometimes to shrink the iris tissue and help me to get a good grip. But it's always advisable to clean myocol really thoroughly because it's may cause postoperative membranes and reactions. I use 10 or Proline with straight needles, and you can tweak the needle to your desired curve. Here comes the importance of multiple paracenteses I used at the beginning of the surgery. To find it easy for entrance and exit of the needle, it is often tricky to have a good grip from the iris. I use simple sliding knot that I usually tie at the edge of the wound. You can use seepster or 4 throws technique, whatever suits and works better in your hands. Be very careful because the iris tissue is very friable, and also be very careful when you tie the knot so it is very tight. Although it's so debatable to use air at the end of the anterior segment surgery, but I always love to use in such complex cases to protect the decimi from the manipulations I did during the surgery, and also to help to constrict the pupil. Thank you for watching, and till we meet again in the next video.